Good morning. I think we have now a growing audience and perhaps a few more people will be coming in. I would like to welcome you to session 2.1 on navigating demographic transitions, impacts, and implications for human resources for health. I'm privileged to be your moderator. I'm Ritu Sadana, and I'm head of WHO's Secretariat for the UN Decade of Healthy Aging. And I lead our work on older people and aging and facilitating implementing a life course approach to healthy aging. We have a distinguished set of panelists. I'm going to start with Dr. Mithoni Karanja, who is the one panelist online. She's the director of Kenya's Human Resources for Health Advisory Council, spearheads national health workforce policy and system strengthening, and published Global Health Researcher and Women Lift Global Health Fellow. She brings evidence-based leadership to the HRH dialogue. With us here is Dr. Butsakorn Loranjan, and she is the director of the Institute of Geriatric Medicine, having previously led the Institute of Medical Technology Assessment within the Department of Medical Services, Ministry of Public Health, Thailand. She is a specialist in rehabilitation medicine with extensive expertise in clinical epidemiology, disability advocacy, and healthcare research. We also have Professor Ren Mingui, and he is the Professor of Global Health in Peking University School of Public Health, Beijing, China, also Director of Peking University Institute for Global Health and Director of Peking University China Center for Health Development Studies. I will also add he was an Assistant Director General at WHO in Geneva. Dr. Kenneth Ronquillo is the former Undersecretary for Policy and Strategy Management of the Philippine Department of Health. He's currently faculty at the Ateneo School of Government on HRH Management and Development in Philippines. So I'm really hoping that our conversations and your inclusion in the as we speak will provide us plenty of information to address the three objectives of this session, which include to explore how demographic shifts are reshaping the demand and supply of the human resources for health, to identify what types of human resources for health are needed and how countries can develop and retain them, and to share innovations, policies, and practices from a diverse set of countries and stakeholders. We will conduct this session in three parts. We will have an introduction that I will give. Then each of our panelists will provide country insights on challenges, then discuss collaborative approaches to solutions, and then we will have a specific third round on the International Code for Health for HRH that Dr. Ken will be leading, given his very key role in the development of the code. And then we will open it up to questions and answers. Now, in terms of giving background, I think from the plenaries, we've had really a rich discussion on global and regional demographic changes, including declining birth rates, aging populations, and migration trends. And I think yesterday morning, we also had a range of scenarios for 2100. I will give a little bit of background specifically on older people, but we know that this session is not only covering older people, and this will be evident in the discussions. So just in terms of the aging context and the relevance for the human resources for health, we have estimated that in 2020 that at least 142 million older persons were unable to meet their basic needs, food, shelter, clothing. That's about 14% of older people around the world. We also, in discussions with and gathering data, actual data from countries, that about only 25% of almost, out of almost 200 countries that belong to WHO, had collected some comparable information on health status. I'm not talking about disease, but on health status and functioning, or their physical and mental capacities that was comparable. We also know that more than 80% of the global COVID-19 related deaths early on in the pandemic occurred among people age 60 and over, and these were concentrated in different places as well. We've done a recent survey on understanding the number and competencies of geriatricians, and from about, I think, almost 100 countries that we have data on, this ranges from less than 1, and then a few countries more than 30 per 100,000 persons age 60 years and older, clearly highlighting cross-country disparities and, in many cases, severe shortages, particularly in low and middle-income countries. Other estimates are that about 65% of older people will probably need care and support from others to perform activities of daily living. Unpaid informal care accounts for about 80% of all long-term care provided in Europe, while formal care services account for the remaining 20%. That's a figure for Europe. It is something that, if in Europe this is the case, we know that other countries that it is sometimes even more than 80%. Globally, we believe, based on survey data, that about 16% of low-income countries provide some kind of support for unpaid informal carers. When looking at our global sort of agendas, the Sustainable Development Goals do not have any specific indicators for the health workforce in relation to older people or in terms of migration. But we know we can strengthen systems, and we have looked at many different ways to improve the way we think about what can be done, what are the competencies needed, and then how to get those competencies among the individuals, the range of individuals who provide services. So on the aging side, one of the things that we've tried to really articulate is looking at the continuum of care that should be provided to older persons. And in WHO, we've formulated this as integrated, person-centered care that includes a range of services from health promotion to rehabilitation. And this is really to meet the needs of health and social care of individuals. And the second component is long-term care, which includes palliative care for individuals who need this. And this is really trying to promote and include integrated services that may be given in different locations and by different providers, but to have a system of sharing of information so that it really is person-centered and respects the rights and values of older people and their families. But what we have also promoted very clearly is that long-term care, for example, is not just about institutional or residential care, but really should be focusing on providing services in homes and communities. We think that based on the figure I provided earlier, that support to caregivers needs to be considered as an urgent priority. And I think many of you know the universal health care coverage box, where we try to extend services to all the older people who need them. And we want to ensure that the costs are reduced so the out-of-pocket expenses are not at all onerous, and that we need to also ensure that the service delivery is integrated across health and social care. There is several pieces to support solutions in this area. WHO, for example, has published several, I think, really strong evidence-based guidelines or normative guidance to support what are the actions that can be done based on evidence or should be done. This includes, most recently, an update to the Integrated Care for Older Persons, also known as ICOP handbook, which really focuses on supporting care in community and primary care settings. We also have a global framework for countries to implement long-term care, and recently released a package of long-term care interventions that could be included within national UHC services. This is to say that we are building the evidence base, and based on these suggestions, recommendations, we believe that there are several implications for the health workforce. We should be building capacity on how to deliver person-centered integrated care across the continuum. We should increase technical guidance for quality of care, focusing on age-friendly primary health care, and also informed, and this is really important, by the engagement of older persons and their families in supporting the documentation of need and the expectations they have. The approach to try to integrate, finance, and deliver essential UHC packages for older people occurs at each country, and we want to encourage learning and sharing of experiences. What's really important is we're not pushing one model, but try to really clearly communicate that the approach taken has to benefit from existing human and infrastructural resources. So rather than talking about the type of caregiver or health professional, we are focusing on the competencies that should be delivered. And then the discussion on how that happens is within each country. I want to end on just two figures because one of the things that WHO is been mandated by the United Nations General Assembly is to lead the technical implementation of the UN Decade of Healthy Aging. And we have been following, in discussion with countries, progress on different policies that they put together and then implement. So I want to just show two in terms of the progress on two indicators that are relevant for the provision of care for older people. One is the number of countries with national policies in place to support comprehensive assessments of the health and social care needs of older persons. This is step one in providing integrated care for older people. Since 2018, from almost 194 countries, we see that there has been an increase in the number of countries. Unfortunately, we still have about 60 countries that have not responded, so it's not a complete picture. What we can see right now is that it's increasing, but it's still only about 50%, or about not quite 100 countries. So we have a ways to go in both understanding and documenting. Second, for those that have responded, we are concerned that more than a third have said that they have no resources or very limited resources to implement integrated care. Moving to the area of long-term care, the number of countries with a national policy on long-term care, whether addressing home-based, community-based, or institutions when needed, has also increased. There's a bit of a plateau since 2020, and our preliminary data show that that plateau continues, also around 50% of all WHO member states. And a bit similar that about more than a third of countries who responded also say they have no resources or very limited resources. So it's within this context that we're operating to try to understand how we can not only provide the technical guidance, but really work with countries so that they recognize and allocate the resources that are needed. And very importantly, this includes the health resources for health workers. I have 2 slides left. One is that we recognize that in terms of the response to demographic change, it is not only about older persons, it's also about changes in fertility, it's changes in the age structure of the population. So we have tried to couch the response to increasing and adjusting and sustaining capacities of the health workforce within a life course approach, recognizing that in each stage, whether it's newborn, childhood, adolescent and youth, adulthood, or an older age, there are different types of capacities and competencies to encourage optimal development of every human being in terms of their physical and mental capacities, the ability to build reserve and maintain health, irrespective of disease status, and then to be able to maintain well-being even if there are declines in health. And for us, this is really about the model of and the thinking of optimal development and healthy aging. I want to end this introduction just acknowledging the terrific field visit that PMAC organized earlier this week, where we had an opportunity to visit in Ladswai municipality in Thailand. It was about an hour and a half here from Bangkok. A home and community-based care workers, as well as a community-based clinic that provided services for older people. And I had a long chat with the caregiver pictured here, who, after retirement, volunteered, and she does receive a small stipend along with a small pension. Very enthusiastic. She took 70 hours of pre-service training. And then already as she's providing care for several people in a community, she decided to also pursue an additional 240 hours of in-service training to be able to perform a few additional procedures under the supervision of other providers. So we're going to hear more about the case from Thailand, but this is one example, I think, of valuing a range of providers. And I think the keynote speak we heard yesterday morning from Martha Chen, I think also reminds us of the importance of ensuring that the range of often women caregivers are fully valued and supported. So with that, I'm going to stop this presentation, and maybe we can just stop this. And I'd like to invite our first panelist, Dr. Butsakorn, and let me.
Yes, thank you very much, Ritu, and good morning, everyone. I'm very it is my great pleasure to be here today, and this is a great opportunity for me to share the Thailand experience in addressing the challenge of the human resource for health in the context of many pressure in Thailand, especially in the rapid population aging. At first, I like to start with the important background. Thailand is at a critical junction in its health workforce development. While the country has a long history of success at its universal health coverage, and of course, as Ritu mentioned for the last slide, we have the effective village health volunteer programs. It is currently navigating a perfect storm for us about the demographic shifts and, of course, about the systemic workforce pressures. Thailand is entering a super age society by 2029 to 2030. We have the total populations about 66 millions for official registrations. The life expectancy at birth for males is about 73 years and the female about 81 years, whereas the healthy life expectation about 68 years. That means the most of our elderly people will face about the dependent state before end of life. These need the increased risings of the palliative care and end of life care. At the same time, our working age population is declining, while the healthcare demand continues rising. This is consistent with the health information. We found that from the outpatient department data, the most frequent visits involve change from the communicable disease to the non-communicable disease. The top three most frequent conditions in the OPD are hypertension, diabetic mellitus, and dyslipidemia. And of course, we also found that there is significant rise in age-related degenerative conditions such as the visual problem for the cataract and osteoarthritis. And of course, about this for the NCD remain the leading cause of our mortality in Thailand. About the NCD, of course, these two point that we need to provide the long-term care and of course the long-term monitoring and the medications. The demographic shift puts strong pressure on our health workforce. And of course, about the health system formations. As you know, in Thailand, we announced about the universal health coverage. It's about 70% of our population under the universal health coverage scheme. And the second length is the social security scheme. And the third, about 20% of the social security scheme. And of course, about the third one, under the civil servants health benefits. Less than 1% of our population under the other insurance or don't have any benefits. For this slide, I'd like to show about the critical shortage and the geographic mismatch. For the example, only one type of the personnel about the physician deficits. Currently, Thailand has about 25,000 physicians actively working in the public health system, out of the over 64,000 registered doctors nationwide. For the doctor to population ratio remains high, as shown in this slide, is about 1 doctor per 1,500 populations in average. But in the rural area, especially in the northern east or the northern, we found that the ratio is very high. 1 doctor per more than 5,000 populations. Contrast with the Bangkok, the capital, very dense of the doctor. The ratio is about 1 doctor per 500 populations. This shows that some health regions operate only 60 to 65% of the required workforce, leading to the service gaps and inequity. Our health workers face increased workloads after the end of the COVID-19 pandemic. We also face with the aging patients. And of course, as I mentioned, it's about the rising of the evidence of NCD and other chronic disease. This leads to burnout, retention challenge, and reduce the service quality. The traditional reactive care should be concerned. It's not proper now. Now, many policy and strategy, and of course, about active plan, we try to shift from the reactive to the proactive. We highlight about the primary care, and we try to raise the awareness and the health literacy of our people. We encourage the healthy, especially the elderly who retire, to help us to work along with the health professional to encourage the health promotion and of course try to strengthen the system of disease prevention. And so about the treatment, we try to choose and try to assess the variables for which technology can help us and to cope about some area that need the specifics or specialists. Of course, as I mentioned, now we face with the shortage of the workforce, so we try to develop in the health parallel to the other issue. This one of the campaign that we promote for these 5 fiscal year, we pivot from the traditional healthcare to the health economy ecosystems. Thailand can shift for this because now we analyze that health is now both a social investment and an economic driver, especially in the aging society. We should concern a lot about the challenge, about the human resource for health, not only about the numbers, but about the sustainability, equity, and of course, we need the system transformations. As I mentioned, it's about we focus on and highlighting the healthcare business aspect, especially about the wellness economic boom, with the highest wellness market growth rate in 2023 is about 20% of growth rate. Yes. However, for this healthcare economic issue is another significant factor that drive our health personnel in the public health system move to the private sectors. This can call the internal brain drain. As I mentioned, it's about the importance of rising NCD. We found that NCD accounts about 75% of all death in Thailand, causing billion loss economic productivity annually. This underscores the need for proactive care, as I mentioned. And of course, we also concern the continuum of care. That means after the patient survive from the treatment, the proper treatment, the variable treatment, after that, we try to enhance and strengthen the rehabilitation. And of course, parallel with the community-based rehabilitation. We launched these campaigns and the policy under the service plan that support from the Ministry of for Public Health and the non-government organizations. Nowadays, we highlight the service plans about the intermediate care. That means to strengthen the rehabilitation in both institutional and community-based rehabilitation. And when someone needs long-term care or continuum of care, we try to develop the human resource about this in parallel work together with the professional and village health volunteer. And of course, we try to strengthen and transfer the knowledge to the family caregiver too. Nowadays, we have the village health volunteers about more than 1 million throughout our country. And of course, about the caregiver, that means they should receive the training course before practice about the caregiver in every village and work together with the care manager who can contact or work parallel with the personnel in the health promotion sub-district hospital. Thank you very much.
Thank you very much. I understand now Dr. Matoni is online. Dr. Matoni, the floor is yours.
So, greetings once more. I hope you can see my slide as well as you can hear me.
Yes, please.
Okay. So, begin with, I'm going to say my apologies for earlier. Internet can disappoint at times. But again, let me introduce myself. Dr. Modoni Karanja, currently the director at Kenya Human Resource for Health Advisory Council. And in the next few minutes, I'll take you through how Kenya is turning a classic demographic trap, a workforce that grows slower than our population, into a live experiment on keeping health workers where they're needed the most. So, based on what the other presenters have talked about, also Kenya, we are focusing on achieving universal healthcare. And for us, universal healthcare has this particular health system levels, of course, being money, medicine, information, primary healthcare, and most important is the people who pull them. So HRH for us is not a priority among many, but it's the operating system, or how will I put it, the heartbeat of the four. So this is a slide for everyone to just appreciate how our HRH flow is in our country. I'd like all of us to think of a tap that has basically like four leaks, where we train 100%, we absorb almost 86%, we retain 70%, and equitably place barely 40%. So today's story is about plugging the last two leaks, being, of course, retaining and equitable replacement. So in our country, the objective right now is absorption, where we have to ensure that the hands we train are the hands that serve. So this slide is for us to appreciate the challenges that we face as a country, but just to give you the context is that Kenya's population is 55 million, and it's currently served by 47 autonomous, decentralized health systems. And the density is at 0.2 doctors and 1.2 nurses per 1,000 population, which is significantly below the SDG threshold of 4.45. So the paradox here is our workforce is currently expanding at 3.4%, but our population health needs are growing faster at 4.7%. So if at all we are not able to pivot now, we are actually looking at a professional shortage of 114,000 workers by 2030. So this slide basically looks at what are the barriers to equitable care. In Kenya, we look at this from three wrongs. We have the wrong number, where we have a 14% unemployment rate among trained workers due to budget ceilings. By this fiscal, we are talking about the fiscal ceiling and not just skill shortages that create the paradox. We have the wrong place in that inequity is quite high, and we have some regions based on the 47 decentralized counties that have 7 times more staff than others. I had the previous presentation talking about urban having a higher health worker population than rural. Also, we have that. We are facing that in Kenya as well. We also have the wrong mood, where we have situations where vacancies can last for even 1 year, and we have burnout also in the few healthcare workers that are currently there. So, of course, that creates a risk, and it leads to strikes, which I've seen quite a number of countries are also experiencing. So this, of course, comes to bedside reality, where this policy cracks reach the bedside very fast, and they turn treatable complications into avoidable death. So I'll take you through what we've done in terms of like the solutions, but I believe we'll also cover in detail when we do the round of discussion. But in terms of breaking the data fog, as I said earlier, we have been operating on 47 autonomous systems that basically they don't talk to each other. So the National Health Workforce Account, which was developed and in support with WHO, we've been able to have comprehensive data on human resource for health in Kenya, and it's the one which is currently being used for forecasting and planning. In terms of the current retention strategies we have in Kenya, I've heard also from the other speakers talking about primary healthcare networks. We also have that, and it uses the hub and spoke model, where specialists in the city support via the Zoom function the rural consultation room. And we've seen a turnover of rural nurses dropping by 18% because they no longer feel professionally alone while doing this. Then we've also professionalized what we call community health promoters, where we give the community health promoter a digital register and we give them a monthly stipend. So we've seen a retention of almost 92% for the last 2 years. Then we also have the AI-enabled Human Resource for Health Registry. This basically gives predictive analytics that flag countries that will lose 20% of midwives in the next 18 months. And lastly, we have the brain circulation bond. Here, we are shifting the brain drain narrative to brain circulation through binding return agreements. So basically, we support our healthcare workers to go for their masters. We give them a 4-year bond, and we've had a default rate of 14% compared to 60% of the historic brain drain. So in terms of our call to action, in that equity, as we know it, is not a feel-good word. It's a design specification. So we need to fund the bond. We need to scale the hardship package and share the registry code. And of course, with this, a lot of countries can also learn from each other. And I like ending my slides with a final quote, where we talk of universal health coverage. It grows when staying becomes the easiest, most rewarding choice a healthcare worker can make. So let's build systems that will be too attractive for the healthcare workers to live together. So with that, let me say thank you. Asante in Swahili. Thank you.
Thank you. I would like to turn to Dr. Ken.
Yes. Good morning, everyone, and thank you for the opportunity to share the experience of the Philippines in strengthening human resources for health. Well, the Philippines is an archipelago of about 7,600 islands, and we operate under a devolved health system. On one hand, decentralization is good because managing service delivery is up to local governments, but it also has its sides, fragmentation, especially in wide disparities in resources, in capacities, and in governments. We have a big population that's about 115,000 population. Looking at the distribution, the biggest workforce or the workforce is about 67%. We have a declining young population, about 27%, and 6% of these are the aging population. The median age of our population is 27, but in 10 years' time, that will increase based on projections to about 35 years old. And we see that in 10 years' time, the Philippines will be labeled as an aging society with a doubling of the elderly. We see also the distribution of the health workforce, almost equal distribution amongst private and public facilities, but we see the opportunities are better in highly urbanized areas with tertiary care. And we miss other public facilities and primary care facilities, rendering primary health care, especially for the elderly. We have some backbones to talk about here. We have the UHC Act. We also have the National Human Resource for Health Master Plan. And we have a robust policies on the elderly programs. But as well, we also have gaps. And here we'll talk about the human resources for health. Can we have the next slide? Okay. So looking at production, we're about over a 5-year period, about 27 newly licensed doctors, nurses, and midwives is being collected through the WHO. That workforce does not translate to, as we will say later on, to service delivery. The employment workforce over 10-year period is about 252,000 facilities. And if we translate that to UHC index, that's about 22 per 10,000 health workforce. So the average age of our workforce is about mid-30s. And as we know, mid-30s, these are the people that has had experience, that has had training, and these are the people that also move out of the country for many reasons: better remunerations, working conditions, but also because of other internal attrition that happens. So job insecurity is one, burnout is another one, working conditions is another one. And while we have increased the number of health education institutions here for medicine, nursing, and midwifery, as you see in the slide, geographic and institutional concentrations are also apparent, especially in highly urbanized locations in the country, depleting students from depressed and disadvantaged areas to access these school facilities. So as we work on the challenges, we have put here a few. Adequacy as an issue for health workforce. Why adequacy? Because one, at the local governments, we see the struggle of local governments to attract and retain health workforce, because in the Philippines, we also have very restrictive hiring policies. And we have what we call the personnel services cap budget. So beyond 45% of the budget caps of the local investments for health, you can't, or it will be difficult for you to get more health workers. We also have shortages of trained personnel and specialists. And for geriatric care and specialized care, there's not many health facilities in the Philippines right now, both in government and private, that are offering these types of trainings. Well, competency in terms of training and education, there's an even distribution of these even private and public training institutions that is focused on geriatric care. If we see the type of training that we have now, it's highly focused on hospital care, not much on public health, not much on community-based care, and even for some complex activities like caring for persons with hypertension, with arthritis. So these are illnesses that are common to the aging population. We also have issues on governance. Weak coordination and accountability between tiers of government makes it difficult to provide options for different types of care at different areas. And of course, the Philippines, known as the source country for migration, all the issues that we mentioned earlier actually push through a weaker health system and actively put on migration as a cause, and this brings more disadvantage to lower level facilities. I think I'll stop there and go to the next round later.
Thank you very much. And I turn to Professor Ren.
All right. Good morning, everyone. Thank you very much for this invitation to discuss how the aging's impact on the workforce in China, which is absolutely critical issues. I'm quite. I think we have some common challenges as we hear from Thai and the Philippines. But I will walk through very quickly how Chinese demographic shift, especially rapid population aging, is reshaping the demand for health services, straining the health workforce supply, and what exactly practical solution package that's look like in China. This slide actually just show how exactly demand side from China, which as we understand China experienced a severe tsunami. I hear the terms also used by Thai colleagues. Even the term sounds a little bit negative, but as I said, we want more aging population because it kind of very good symbolic in terms of welfare and social development. But on the other side, when we look at the health development and health service, it is absolutely, unfortunately, the issue how this movement in terms of aging population can bring to us in terms of challenges and others. From the slide, you can see in the 2024, the number of the people over 60s has reached 310 million, which is about 22% of total population in China. And the proportion of people aged 65 and above is 15.6 of total population. But if you look at this sort of a super aged population, that's aged 80 and above, the China in that same year will count for about 3.3% of total population. So in a very quick summary, we can see the speed and the scope of aging in China are both growing very faster. As we hear from other colleagues, it's not just about sort of the numbers and in terms of more patients, it's about the more complex situation in terms of health and physical health and mental health we have to deal with on a daily basis from public health. And meanwhile, over 80% of elderly population aged over 60 have at least one chronic disease, health condition such as hypertension and arthritis. This fundamentally changes the type of care and the way and the demand of care we need to provide. That number matters, of course, because it's directly translating to more outpatient visit, more inpatient episodes, and more long-term follow-up, especially when the system still, unfortunately, heavily hospital centers. I think that's as we hear from other countries as well. This shift to workforce need away from episodic accurate care towards long-term chronic disease management, including medication management, routine monitoring, rehabilitation, mental, and even social psychological care, and coordinated care across all sectors of systems and the society. So aging drives a steep rise in need of nursing, rehabilitation, and long-term care, not only inside the hospital, but across community and home-based care, institution care setting. By the end of 2024, about 35 million elderly adults had difficulties with self-care, which about 11% of the elderly population. Its number is projected to rise to about 46 million by 2035. So the gap is very clear and visible. As demand for elderly care workers exceeds 6 million, while supply remains below that level. And also we have to be very careful with cognitive decline, which add additional sustained demand driver. China has nearly 17 million dementia patients, increasing the demand for professional care and personnel training in screening, management, and the caregiver support. Also on the same demand side, the message is clear. China is not only facing some more health care, it is facing more long-term care, labor-intensive and teams-based care, which much of need to be happen close to the community and home. Next slide will be the supply side. See how we can offer from systems. We both have some good news and some terrible news. The good news is the scale. By the end of 2024, the total health professionals reached about 13.78 million, which is about 3.6% increase over previous year. So you see the number of supplies increasing, that's why we see it's good news. We think this total. The health technical professionals were about 13 million, including 5 million licensed and a licensed assistant physician, and about 6 million registered nurses. So this is great news. At the same time, we have some bad news. This is about bad news. We also call the core challenges. It's not just total numbers. The challenges about distribution and the skill mix required for this aging population. The evidence suggested very clear, the aging can have a threshold impact on the physician density, means when aging reached a high level, it begins significantly push out demand for doctors and nurses per 1,000 people. So it implies that as China continue to age, the workforce's growth may intensify rather than stabilized. The key imbalance is where the staff work. Unfortunately, for the time being, about over 60% of hospitals, staff, professionals, and all health workforces concentrated in hospital rather than in community care settings. And only 34% in the primary health care services, institution, and systems. As we all know, the aging relative care, including chronic disease, follow-up, community rehabilitation, home-based nursing, ongoing functional support, requires a strong primary care and a community platform, not just hospital-based services can do so. So if staffing continue to concentrate in the hospital, and the system will struggle to deliver a kind of elder care that the people completely can do the offer. So long-term care sectors show each sharper constraint, for instance, difficulty working condition, and heavy physical labor, and high communicate demand from aging population, and unfortunately, very weak pay compensatives, and unclear career pathway for this group of workforce, and very low social recognition, unfortunately, also exists with us. So as a result, the providers face insufficient staffing and high turnover. One survey in China report that more than 70% of elderly care institutions face insufficient human resources, and over 60% are troubled by low professionalization and high mobility. It means people retire and move to other working places for the career development and a high pace job opportunity. So in short, even in the medical workforce expand, as we said, it's good news, but the long-term care workforce may require a bonding constraint unless its employment models has been changed. So supply chain is very clear from China is more doctors, nurses being trained, but the demographic change demands that we reconfigure the workforce by location, by skill and roles, not merely number of doctors and nurses training in the future. So a little bit of a quick presentation about target solution. One is optimize workforce structure, strengthen the grassroots and the community teams, and then improve the payment for these workforces in the rural setting, and good training, and very clear design and for the past career pathway, and the social recognition has to be raised as well. Third one is broaden supply channel and mobilize non-traditional health workforce resources that we hear from our professionals as well. We need a more non-informal sort of health workforces, but with well-trained and good pay and full recognitions for them. And also, last but not least is, as we hear from other colleagues, AI. AI and smart technology has been leveraged in China, many places to provide some new and innovation solution as a providers and also the way of management. So in that regard, I want to do a very quick sort of core takeaway is China aging is very clear, and which is producing the health workforce challenges, and which can be managed, manageable. But the question is whether we can manage very critical challenge in terms of structure and allocation and incentives. And supply increasing, but most supply unfortunately concentrated in the hospital. In the long run, we have to make sure that all the supply have to be reallocated, decentralized in the grassroots level hospital. So in that regard, I think we can have a solution, but the question whether we can maintain the solution in the long run with all support from government and all stakeholders. With that, I thank you very much for your attention.
Thank you very much. So my first question is to Dr. Muthani. I hope you're online, that you're there, because your presentation on the challenges were really clear. In terms of the barriers to the workforce for effective healthcare delivery, you mentioned the three wrongs: the number, the place, and the mood. Can you give, for one of those, a little bit more details on how this is specifically compromising equitable care?
So, thank you for that question. I can talk about one of the issues we've had. I think I'll talk about the number. Basically, just to reiterate what I said, Kenya currently has 47 autonomous, decentralized governments. And I've seen, I think, amongst my colleagues who've presented, there's another country which is also like that. So that faces challenges in that. Let me talk about the city center, the capital being Nairobi, in terms of the wrong number. Now, Nairobi, what happens is we have a high influx of public, of private institutions, of private institutions. So what happens is that we have a lot of doctors, a lot of healthcare workers, who are, a majority of them are in Nairobi. So we tend to have, and a majority of them being in Nairobi, we also have a number of training institutions in Nairobi. So we have the general doctors being so many in Nairobi, as well as a lot of specialists as a result of that. So what happens is we have a situation where a lot of Kenyans, especially with the context of aging and needing specialized care, they have to come to Nairobi to be served here. And also, what happens is the reality of the ground is that within the capital city, even the national government and county government in Nairobi, they pay doctors and healthcare workers way much better than in the rural areas. So we have a lot of influx of doctors coming here. And then we also have the private hospitals also paying doctors quite well. So by the wrong number, I mean we have a lot of doctors, healthcare workers within Nairobi vis-a-vis rural. But I also talked about the solutions, and I've seen other countries also reiterating that for community health promoters and primary healthcare. I hope I've been able to answer the question. Thank you.
Thank you, and we'll come back to on solutions. Dr. Butekorn, you mentioned that in part of the challenges, there were critical shortages in zone 2, 4, and 8 that affect the distribution and equity and access. Could you give us an example on any one of those zones in terms of a bit more detail on that challenge? And you can even let us know a little bit about what you're doing, particularly as solution. Thank you.
Thank you very much. And I can share about the experience of Thailand, about the solutions for this shift of about the shortage of the HRH or human resource for health. Of course, after the finish of COVID-19 pandemic, at that time, our health system abruptly changed. Now we are using the digital health, artificial intelligence, and of course about telemedicine. Among the pandemics of the COVID-19 at that time, we cannot move from the home. So we use the telemedicine. The number of the use of the telemedicine is abruptly increased. This can help our workforce because this can reduce the routine workload and allow the professional to focus on the complex care. And of course, we also strengthen the community-based elderly and vulnerable care system. By the first, we already have the roles that empower the local governments, and nowadays we have the 9,800 health promotion sub-district hospital under both the Ministry of Public Health and the Ministry of Interior. We try to find the best way to empower the local government to provide the proper service that include the rehabilitation, the community rehabilitation, the day care, the respite care, the hospice care. And of course, we think that we can strengthen the local government, can serve and can solve the specific problem in the rural areas. And the second one, we should build a qualified care workforce. That means we should strengthen and collaborate with the interministerial, Ministry of Public Health, Ministry of Interior, and of course about the Ministry of Education, how to upskill our caregiver and the care manager. And we transfer the knowledge and the skill, and of course about the technology to our village health volunteer. About the third one, we try to establish the sustainable well-being fund. We try to create and decide about these well-being funds that should be work together with the worker insurance, and of course should be considered about the government co-financings. This should be help us in sustainability. The fourth one, that we try to support the family caregivers to introduce the comprehensive policies to support the family caregiver in both physical and the mental supports. And of course, we should include the financial assistance. The last one, we try to promote the community and the social enterprise in the act of the service providers and the educational hubs about this. So I can summarize that the key policy strategy to address these challenges. Nowadays, our ministry, we launched the roadmap about the full strategy. The first one, as I mentioned, nowadays we divided the area for our country into 13 health regions, and we try to promote the one province, one health region, one hospital model. For this fiscal year 2026, we initiate moves away from the rigid district-based hiring. It allows general and the specialist doctor to move flexibly across the province under or within the same health regions, ensuring that the specialized care reach the underserved area without requiring the permanent transfer of the physicians. The second policy is about the strategic graduate allocations. Our ministry has prioritized the allocations approximately about 2,080 new medical graduates from the medical school, with nearly 2,000 reserved strictly for the 10 provinces with the most severe shortages, such as Bungkan, Sa Kaeo, and Mae Hong Son province in the rural area. The third one about the policy is about we should use the digital and the AI upskilling. Policy focus has shifted from the more staff to the smart staffs. Initiate include the three principles. The first one about the coverage, digital health, the strategic priority to integrate digital health platform and the health information system. The second one, as I mentioned, we highlight about the AI integration by training workforce to use AI in pathology and radiology, and to improve the productivity and reduce the burden of the specialists. And the last one, we highlight in the village health volunteer. We empower the 1 million village health volunteer with the smartphone-based surveillance and telemedicine tools to handle about the primary screening. The last one about the policy, about the financial and the career incentives. Very difficult, but we try to increase the comprehensive heights. There is some gaps between the public system and the private sectors, especially who work in the high workload or the red zone area should be considered first. And the second one, we should consider about the standardized academic professional framework to consider about the career progression for the staff who work in the rural area. Yes, of course. Thank you very much. This is the solution for Thailand. Thank you.
Thank you very much for outlining some of the key strategies. Some of the challenges are common across the different countries we've heard from, including the career pathway. Picking up on one item you mentioned in terms of the differences between public and private, I want to turn to Dr. Ken in terms of the presentation you gave on Philippines. You noted that about half the workforce is in the public sector and the other half is in the private sector, and that decent work was one of the themes. How different are the conditions in terms of the way you've expressed decent work between the public and private? And is there learning or a shift or a movement to try to equalize upwards the approach to decent work? Thank you.
Well, yes, as I mentioned earlier, a little over of our health workers are in the private sector and in the government sector. That makes a very big difference in many ways. One, looking at compensation and the salaries, a little better at the government sector than in the private sector. But as you go up the ladder, better salaries goes up to the private sector than the government sector. So there's a shift of health workers as they go up the ladder from public sector to the private sector. Another one is looking at occupational workloads or burnouts. So if we compare number of services and patients, a lot of patients really are in the government sector. And with the shortages of health workers, there's plenty of burnout or much burnout in the government sector over the private sector. So if we look at young graduates now in the Philippines, they prefer to go to the private sector, do some moonlighting activities, and then later on, when they are decisive of their future, start to go to the government sector. But that's how it is. That's happening in our country now. The third one that we see is that learning and development, while very good in government sector because the number of cases are all there and there's much learning opportunities there. technology is also at the private sector. So there's a balance between where should I go, at the private sector or at the government sector. It's a balance of having both all together. But in essence, as we go through these strategies, we see that data is very important, because if we have the data, then we can make better health labor market analyses. We can forecast our shortages, and we can design targeted interventions as well. The second one that we'd like to look at is actually looking at what type of health workers do we produce, and where do we put them in the right communities. So at the education level, actually improving our curricula, as I said earlier, these are mostly on hospital-focused curricula, and we want public health and community-based care more in the curricula. And to put up some grants for students who are unable to go to the health sector, and then return service to communities where they are most needed. We have some policies that talks about salaries and incentives for both the public and private sector. What we're trying to do now is push forward at least similar or same salaries and benefits amongst national and local governments, but very difficult to work on that when we go to the private sector. Perhaps I'll talk about migration when we go to the next set. But the fifth one that I'd like to talk about is that we will have to really push for better human resources for health plans at the local governments, to teach them how to allocate resources, teach them how to manage workforce, and to enhance accountability, and to partner with the private sector, because there are private sector around the area. And then the last one is actually to build HRH networks. This will be private-public mixes in healthcare as we go through delivering the types of services that we want to offer.
Thank you. I'm going to turn to Professor Ren. You mentioned that already now 11% of older people have difficulties with self-care, and that there's an expectation of 16 million more in the next 10 years, and that NCDs, including dementia, is a key issue. We heard yesterday that diabetes is going to be the number one, at least in the next 75 years. And I think picking up on what Dr. Ken mentioned, you also noted that it's the need in the community level, and yet the concentration of workforce is in the hospital level. What are the approaches, or what are the challenges to move people to community-based primary health care, not only for older people, but also for older people, for the workforce?
Yes. All right. Thank you very much. That's a very good question. In China, based on what I understand, there's fields of we call the policy tools to encourage more workforces, decentralized, and work in the community level to provide elder care. Number one is rules and regulation. We have a government issue very clear to target in terms of future. They want to have more than 50% of primary health services provider to have geriatric wards or departments, and then specialists. So make sure that, because now I said capacity is big issues. That's why there's very clear rule. So 50% of a primary health care provider will have the geriatric wards or departments. The second target, what I understand, is they want to have over 60% at the minimum of all hospitals in China to have a geriatric department and wards as well for total China. And it's big clear. So this is why the rules and targeted by government is very important, the policy. Second point is there's a huge investment in terms of infrastructure. As we understand that you need more skill, you need a complete difference of devices and facilities to provide the services for elderly care. And unfortunately, the primary health care services provision and also and hospital, they can't have the capacity. That's why the huge investment has been delivered by different level hospital to make sure the hospital can update the facilities and which can be easily used and provide services for adult care, and also the AI. AI is not something you buy the computer. You need the devices. You need a very good online system signal as well. There's also infrastructure has to be invested by governments as well. The third issue is we need good empower to make sure the community, when they need services, they go to the primary care rather than go to tertiary hospital. So the message and also education and campaign has been widely taken by not only by the tertiary hospital and also by the provincial government, also by the primary healthcare service to make sure when the service is coming, of course, because I said in China, the individual can go to tertiary hospital without any difficulties because the health insurance can give you permission free from wherever you live to the very good tertiary hospital without any difficulties. But now we try to link when the diagnosis is being made in the tertiary hospital, the individual and the patient can reference to the grassroots level, the primary care service for adult care in long-term care. So that can be taken over. And then with very clear information monitored by the professional in the tertiary hospital to make sure all the follow-up in the community-based primary care setting can be qualified and overseen by the person in the tertiary hospital. So that system has been set up in many provinces and cities. That's also very important for us to know why, to make sure the incentive, not only incentive to the healthcare system, also the incentive to the consumers from consumer side to use more intensively the services which is already available, accessible in the PHC settings. Thank you.
Terrific. I'm going to move to the second round where we'll just have brief responses because we have one more round as well. I'll start with Dr. Busakorn. You mentioned very interestingly that in terms of your strategies to navigate not only the shortages but the distribution, that there's no longer rigid district boundaries and care workers at different levels, professionals can move. Can you give us a little bit of insight on what enabled that shift? And to what extent were these ideas of the community supporting the shift? Thank you.
And of course, before I mention for the next about the WHO International Code for but for about the I think not sure for this right. Okay, about the support for the community. First, we should launch from the strategy and the policies to support. Nowadays, we set some specific or highlight some service plans that should concern. That means we should provide about the system, about the financial system, about the technique, and of course, how to enhance the human resource. We should empower both sides from the provider side and of course with the health volunteer, and we try to skill up about the caregiver. That means about the paid caregiver and non-paid caregiver in the system. Yes, of course. Nowadays we try to strengthen, as I mentioned, about the local government to help us. We work together with the different Ministry of Public Health and Ministry of Interior to work together to solve this problem and how to design the proper service for the community level. Yes, to reduce the inequities about this. Yeah, thank you.
Okay, thanks. Thank you very much. I'm going to come back to Professor Ren. Given what you've described in terms of demand side and the supply side and the gap that you're addressing, and also in terms of potential solutions, looking at workforce structure, the conditions, supply channels, China is a huge country. how is innovation and experimentation from across the country being incorporated to shape these solutions?
That's a tough one. But probably China have the unique political system. That's the ruling party with the country for more than 7 decades. So this cross regions collaboration is one of the critical strategies to boost low resources provinces can catch up some fancy and rich provinces at almost on same speed in terms of economy and social development. We also have very good system in terms to link. We call it twin collaboration, even in the house. So every poor resources province have their counterparts identified by central government from the rich provinces to work and support in terms of professional deployment from rich provinces to work and support in the counterpart way. And also train the more local professionals from the low resource province in the rich and fancy and tertiary hospital. This system has been with us for more than five decades. That's why even in the low resources province, the health professional can easily access to the first class or national levels health professional for training. And now it's because AI and the new technology can make it more easily. We set up some e-health system and then funding from central government to support this system and to even there's in-person training courses as well. This is number one. The second point is especially about aging, as we understand. But normally, it's good situation is now we look at the aging population. Of course, on average, all the provinces, even the poor province, you see the aging speed also very fast. But unfortunately, at the same time, you see the more aged population, they moved to the rich areas to some more warm climate zone for their retirements. And then there's issues how the places normally don't treat this patient because the patient they kind of we call them migrant as well from poor region to the rich areas and to the coastal areas to the warm region. So this is another challenge, especially when looking at the cross region in terms of aging, health, elder care. And the good thing is because this aging population migrant also brings some retired doctors, nurses, who leave the places already work for more than 5 probably decades in the poor areas and then immigrate to the other places, but the system can allow them to work as retirees, health professionals to provide elder care in their community. So this is also a good thing. We can attract some retired doctors, nurses from the poor resources, poor areas to rich areas, but provide services for the migrants, the colleagues who immigrate from the poor provinces to rich areas. Of course, the question is whether this kind of migrants can leave the health workforce, which is much needed in the poor areas, in the vacancy. But so far, we don't see that became issues because this kind of migration in terms of retired doctors and nurses not big of issues. So clearly, so far, and also I said, the increasing doctors and graduation from medical school can provide some continuous supply in that regard so far. But like I said, the cross-region collaboration in terms of work sources is absolutely critical issue. So far, we have some solution. We perceive this system, as I said, can be maintained and supported by central government and by the community in the year to come. Thank you.
Thank you very much. I'm going to turn back to Dr. Ken. Actually, something that Dr. Muthani mentioned in her solutions was about brain circulation. And I'm going to come back to her in a moment about that. Given the density map you showed for the country across the islands and even within the islands, how do you see this challenge considering the devolved setup in your country in terms of improving the circulation even within the country? You spoke of internal migration as well. Thank you.
Well, excuse me, that's a challenge, Rito, especially in the Philippines. But what we have done here is that put up a program that we call the National Health Workforce Support System. It's a system that deploys health workers in communities where they're most needed. So first, producing the right workforce for the right communities, and then putting them into this program, giving them the opportunities not to just serve the communities, but actually to grow with the communities, and then to develop health systems, local health systems in the communities. And potentially, if we're able to do that across depressed and disadvantaged areas, then we have a cadre that is well developed, wanted to work in these areas, and eventually upgrade the types of services that we have. So that's one of the biggest programs that I can describe now. We have also another program which we call the Doctors to the Bars program. These are doctors that we send to villages, and while they're in the villages, we give them some courses on health systems development. So it's an applied course, actually. So over a 3-year period, we hope that as they learn and as they apply health systems, they're also they gain the trust of people in the communities. They're loved by the people, and then convince them to, in fact, stay in these communities. So a lot of our doctors actually stay in these communities, and that's one way by which we see to it that health workers stay there and reduce the mobility of health workers as we speak.
Thank you. I'm going to come back to Dr. Mathoni now. Just to confirm, she's online. Of the various homegrown solutions you mentioned, one of them was, I believe, PHC networks. Could you give us a little more detail about how a PHC network works, not only in Nairobi, but potentially in another area or part of Kenya as well? Thank you.
So, thanks. I hope you can hear me. With regards to the PHC network that we currently have, and I had initially said that it's a very huge focus, particularly for the current government, because we've had a situation where our urban areas are heavily influxed with healthcare workers vis-a-vis our rural areas. So as I said earlier, we have a hub and spoke model. It's basically using the aspect of teleconferencing. So most of our specialists, especially in terms of the pathologists, the radiographers, are the ones we mostly use. And the primary focal healthcare worker that we are focusing on in the primary healthcare is they're called family physicians. I don't know if you have that in your other countries, because they're well versed in various aspects of healthcare. So we have family physicians situated in Kenya, within Nairobi, but we also have regional family healthcare physicians in the various sections of the country. So what happens is that the healthcare worker in this dispensary, at a rural dispensary, is able to summarize a case. When they summarize a case, because we even have what we call, it's like a template. They're able to summarize some of these complicated cases. And with that, we have multidisciplinary teams within the rural setup. So with that, once the case is summarized, the multidisciplinary teams are able to have a look at it. If at all they're not empowered enough to sort out the issue, it goes to the regional level, where we also have the family physicians. If at all it's also not being able to be sorted out, we have more complicated cases that are sorted out at the urban or Nairobi level. That's how it works. And all this basically using teleconferencing, the Zoom function. I hope I've been able to address the question. Thank you.
Yeah, thank you very much. We're going to turn to round 3 to discuss a bit about the international code And I'm going to turn this over to Dr. Ken, and then we'll have a few minutes to be able to have the questions from the audience as well. Please, the floor is yours.
So thank you very much again, Rito. I hope everyone is adept on what the code is. But just a little background. This is the 15th year that the Code of Practice is present. It started in early 2000 when there was a clamor by member states of an ethical recruitment of getting personnel from middle and low-income class countries to more developed countries. So there was a call to WHO to develop the code. It took about 6 years of negotiations to develop the code. But the code really talks about ethical practices and ethical recruitment. It's a reference for member states to put up their institutional and legal frameworks. It's a reference to shape their bilateral and multilateral agreements. And it's for the source country situation. This is an area where they can put up better relationships or agreements. So in the Philippines, we see that the code is relevant. It's a strategic framework that we see in developing ethical recruitment and global solidarity. But unless you put this code or you apply the principles of this code in the reforms that you do in your country, then that becomes more effective. Otherwise, if you just put up the code, you don't see it. But from the intent of the code in 2010 until this time, from 56 countries, about 105 countries are now reporting the progress of the code. In the last regional consultations, there are about 110 countries that joined the regional consultation. So, which means to say there's already increased awareness of the code, better monitoring for data, and hopefully these countries are also putting in the code into or translating them into national policy so it becomes a binding policy. But well, that's the experience of the Philippines, but we'd also like to see the experiences from Thailand and from China. How has this code been applied in your health workforce as we did in the Philippines?
First, I should like respond first. In Thailand, I think about apply the code in our country is particularly different because Thailand we act as both the source and the destination country. Yes, for the source, we lost many specialists to the West, and of course about the destination, we attract about the neighboring health worker to serve us as a global medical hub. So if we try to apply the code in our country, we should prioritize the way to strengthen the health system. Especially, we should raise the retention pillar to reduce the brain drain. Yes, of course. And I think another issue that we should try to establish about the centralized tracking system for the health worker migrations. This involves about the monitoring not just who live, but should be document that why they live and where they go, and regular reporting the statistic data to our ministry and of course for the international to the WHO regularly. And of course we should ensuring that the health professional from the other country who work in Thailand enjoy the same labor rights and the legal protections. And of course about the opportunity for the professional development as the local Thai national. This is the basic one. So I can summarize that when we should apply the WHO International Code for the HRH in Thailand, we should concerns about these four aspects about the sustainability to scale up the domestic professional production to meet the national needs. The second one, about the equality to treat the foreign health worker with the same standard and the right. And the third one, about to strengthen the transparency, sharing the migration data and tracking system. And of course, the last one, we should concerns about the investment to receive the compensation in form of the technology transfer or scholarship, as Kenneth mentions about the bilateral agreement. Thank you very much.
All right. In China, we support the WHO International Code. I remember when I worked in in my government, I'm one of the delegates to join this intergovernmental negotiation process for this international code. We are very supportive to the code, especially in principle of equity and also sustainability, also the mandate, especially to the country who received the migrant doctors, nurses, who that country have to pay financially to the original country for sure. And in China, we don't have too many migrants, doctors, nurses from other country because we are not country migration. And we don't have a sort of a very clear statistics how many doctors, nurses immigrate from other country. Based on my sort of limited understanding in total, probably for time being only have probably less than 1,000 nurses, doctor licensed by Chinese authority working in China on a daily basis. Very limited. In terms of Chinese doctor nurses working out other country, we used to have a big movement more than 10 years ago. At the time, many young doctor nurses get good job in other countries, especially in American, European, and then pay, and then they leave, they immigrate over there. That's time happened more than 10 years ago. I think probably more than 20 years ago. But now we don't see these movements severely make our health workforce China in damage. We don't see that movement because even the few migrants from China to other country, in terms of proportion of whole workforce in China, is very limited proportion. So we don't think it's big issues. Of course, we support this code have to be strengthened in terms of implementation, especially for the country who have high income level and get many doctors, nurses from poor country. I'm sure that will be something very obvious in the future because I just read a few articles based on data. Now is more European country, even Americans, many doctors, nurses retire. And unfortunately, the supply doesn't have enough scale to provide the increasing the demand from supply side. So I think based on their understanding, there are big gap in terms of supply and demand. So in that means that kind of country will have more doctors, nurses from other country and immigrate and paid by these countries. So I think probably this kind of we call the brain immigrant, what we call, will be the seriously make the low resources countries, but lower income country of the health system another round of collaboration in the collapse. So we think the collaboration have to be strengthened. That's why we are looking forward to see how the new code can be strengthened in terms of implementation and update based on the current new areas of aging populations. Thank you.
Thank you very much. This is not specific to the code, but in a session yesterday, there was a question on how could competencies of care workers that are trained in one country be recognized in other countries as a part of the shifting in response to the demographic change. I think this has been a terrific conversation, and I'd like to open it up to the floor if there are any questions to our panelists, including Dr. Murati, who's online as well. Muthoni's online as well. Please introduce yourself and ask your question.
Good afternoon. Good noon. My name is Dr. Kwan Siri. I'm emergency physician and cardiologist faculty at Chulalongkorn University. As my head as a faculty and emergency workforce frontline, I would like to ask the panel, especially Dr. Busakon, from your strategic plan for Thailand, I'm particularly interested in how can we build qualified care workforce beyond digital and AI upskill, responsible for AI with with a strong focus on teamwork, soft skills, and workforce resilience to coping with stress and burnout. No? So my question is, beyond the digital and AI skill, how can Thailand embedded simulation-based interprofessional education as a national workforce strategy to strengthen teamwork, task sharing, team clinical reasoning beyond AI judging, and resilience in an aging society? Thank you.
I'm just going to suggest we hear a couple of questions, so it gives you a moment to think about the response as well. Please introduce yourself.
Hi, my name is Tawfiq Jordar. I'm originally from Bangladesh, currently working at Singh Health, Duke NUS Global Health Institute, also a board member of the Health Systems Global. My question is for Dr. Ren Minghui, but others can join to answer that question too. Dr. Minghui mentioned that in China, there are shortage of 6 million healthcare workers, and also a lot of other figures which denotes to the fact that there is a huge need for elderly care providers. Now, in many other countries actually have a broader base of the age pyramid. That means there are many younger people to provide that services. Considering that, what's your view on like creating an opportunity for other countries, people are younger, people from other countries to provide services, elderly care services where the need is more acute? I mean, is it a good solution, or does it have some other associated problems that we cannot see? I just want to know your perspective on that. Thank you.
And we'll take one question from here before we hear some responses.
Hello, I'm Nishnipa Thawamusit. I'm actually a medical student from Thailand, from the Siraj Hospital. So actually, I'm really delighted from all the discussions above. But I have a little questions on more kind of practical plans or practical procedures for the medical schools or medical sectors on how should we kind of help with the strategic plans, like in each of the countries. For example, how do we kind of manage the declining workforce and also multidisciplinary team for kind of helping with social determinants of health and also the health and also community based, as many person have already discussed about.
Okay, thank you. Dr. Ken, I'm going to ask you to respond to that one. Okay, so please, let's start from Thailand.
Sorry, thank you very much. Thank you for your comment and suggestion. I think your question is very important, and I think you know that in many, about the health issue, we have a lot of problems, but we should prioritize, especially about the critical care and emergency care nowadays. As you know, we are in the complete age society already. So about the ER room, our personnel should be skilled up with the juridic approach, that's right. And of course, I should highlight that the most important issue that how can we strengthen the teamwork? Yes, parallel with the use of value-based technology. That means reasonable price of technology, which we concern. So why this is the reason that our ministry, we highlight that we should consider to assess the proper technology. That means not the high expensive only, but to use the value-based first. So this is, I should adopt this to how to find a way to fill the gap in, especially in, I think it's about the high length of the problem, the health problem, especially about to face the age society. Thank you very much. And for about the school, the medical school, we try to work together with the Ministry of Public Health and Ministry of Higher Education, how to deploy and analyze the and prioritize the health problem and try to, I think we should consider about the curriculum for the undergrad. I mean about the medical school to work together that can produce the medical graduate to serve in majority in the Ministry of Public Health. That means in the key person in the health system, the public health system. And we should alongside with the private sector too. Of course, we should focus in about the wellness ecosystem. This should be considered, but we should balance with the public health that serve the basic need of the people. I'm not sure I can point to answer your question, but I should adopt this in the way that can try to design the proper way or the better way. Thank you very much.
All right. Thank you very much for your question in terms of 5 million health workers in the gaps. How exactly we can solve it? Can we take the solution like immigration and migrants, doctor versus from other countries solve the problem? In the general terms, China we don't have a normally we don't use the immigration as a solution for all the issues, not only for the health, and because we think China already have 1.4 million population, which is also I think probably still number one in terms of total population. Of course, based on what I hear yesterday from Chris Mori, and more country will come with populated status. So number one status in terms of population, number one for China will be taken care by others. But even though we think because for this 6 million of a gap in terms of for the aging and the health services, we think we can solve it because I said it's not a number issue, it's a structure issues. It's a location issue, it's a skill mix issue. So I think that's why I said based on the current strategy and investment package for the next 5 years, what I see all of official documents is going to increase more number of medical doctors by more schools, more medical school, more nursing school founded and established in China. They're going to recruit more young generation to work in the health professionals in these areas, and they're going to decentralize workforces in the community-based level as provision services, not just recruit and immigrate from other countries. I think that's the general response to your question. Thank you very much.
Yeah, just quick, because at this time we're also reviewing the curriculum in the Philippines, and what we're doing actually is looking at more time for public health, more time for community-based curricula, the basic and clinical care courses or topics to be integrated with public health. But one important thing that we're doing now is that early exposure of medical students to the community, exposing them to the community, teaching them how to diagnose the community, seeing innovative solutions in the community. So as early as first year and second year in medical school, they're already exposed in the community.
Well, I think we should really congratulate and thank all of our distinguished speakers, including Dr. Bethoni, who is online. So please join me in thanking them. And also to all of the colleagues from the PMAC Secretariat, including our leaders who are sitting here at the front table, who are also rapporteurs, but they are leaders not only for the future, but right now. Thank you. I've also been asked to kindly draw your attention to take a moment to share your feedback by scanning the QR code on the screen. Don't forget to screenshot your completed evaluation to redeem a daily stamp of evaluation point collection minigame. So we've gamified it. It's terrific. So please, before leaving the room, please make sure to bring with you all of your belongings and come and explore our special events and poster presentations during the morning break and lunch at the front of Convention Hall B. And for those who are interested to join a conversation right now, in the special session area, we are having a quick 30-minute discussion on strategic directions for the UN Decade of Healthy Aging. So you can see me and others there in, I think we'll teleport ourselves there in the next 30 seconds. So thank you again for this really in-depth, fascinating, and learning experience.